basically stopped right after talking about the lymphomas, and we had covered non-Hodgkin lymphomas. I just wanted to revise it one last time, just to talk about a couple things. Let me also find it here. Okay, so the topic of non-Hodgkin lymphoma is a little smaller because actually a lot more in depth is what I mean, because Hodgkin lymphoma there's not much to talk about, right? So Hodgkin lymphoma was just this much from back in step 1, where they talk about the Reed-Sternberg cells and CD15 and 30 and the owl's eye appearance, and then these are the 4 different types. That's generally it. We talked about what it means to have a difference between Hodgkin versus non-Hodgkin, right? So Hodgkin, localized, contiguous, bimodal distribution, Epstein-Barr virus, that's really all there was to it. Not much intensity in a discussion about Hodgkin lymphoma, right? So that we're going to get to, but the non-Hodgkin lymphomas are a much bigger topic, right? They have the division between the two over here as well. They talk about a couple things. They list out in a very rapid form the main guys, and we went over these guys from the step 1 book. And one of the key things I kind of wanted to make sure I point out to you guys is this R-CHOP thing, right? Very important to remember, because they can give you a question where they're trying to treat a patient who has some type of Hodgkin lymphoma and non-Hodgkin lymphoma, NHL. And for the NHL, you use this R-CHOP mnemonic to treat them, right? So you can see that right here. High-grade aggressive NHL treatment is aggressive chemotherapy with a curative approach, and one of the most common regimen, or the general regimen that's used everywhere, is this R-CHOP stuff, right? So you have rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. So you could get a question where they might have listed out 4 of these 5 medications, and then they'll be like, what else should you add? So that's something that you don't want to miss out on, right? And then, of course, treatment of cancer and treatment of most tumors in general can lead to tumor lysis syndrome, where you're killing off a lot of cells very rapidly, which then releases those contents, right? The things that are inside those cells. That's what the key fact on the page right now is talking about. So a lot of things involved with non-Hodgkin lymphomas, right? A lot of things involved with NHL. Very in-depth, very diverse group of cancers where they're either B-cell neoplasms or T-cell neoplasms. And one of the key things to make sure you do is to go back and revise the medications we just saw, right? So here we can see the vinca alkaloids, vincristine. Vincristine and vinblastine go together. In step 1, one of the common questions were often that you had a patient who was taking some medication, they didn't tell you which one, and then they would have the side effect of neurotoxicity, and they would ask you what's the most likely medication they're taking, and it would be vincristine as an answer that you would have to pick. So this thing binds beta-tubulin and inhibits its polymerization into microtubules, which will then prevent mitotic spindle formation. And if you don't make the mitotic spindle, you don't separate the DNA, and that basically, in effect, messes up replication, right? So this is M phase specific. It's M phase specific, and it just stops cells from being able to replicate correctly, which is one of the key things you want to try doing whenever you're treating cancer. And you can see some of the main uses here, but what we're looking at right now are Hodgkin and non-Hodgkin lymphoma. That's what we're working with. Vinblastine is also helpful here, and these mnemonics were pretty clutch back in step 1, right? Vincristine crisps the nerves, and vinblastine blasts the bone marrow, so you can remember what the side effects are. That's one group. The other medication is cyclophosphamide, right? So that's a right here, a nitrogen mustard, right? Cyclophosphamide, ifosfamide. One of the key things to remember with this medication is that although you can use it for these things that they've listed out here, one of the issues with it is that it can actually cause hemorrhagic cystitis and even bladder cancer, right? So a thing you can do to prevent such a side effect is to administer Mesna with it. Now, cyclophosphamide is actually a very high yield medication because not only can it cause this bladder cancer thing that gets tested a lot, it's also a medication that can lead to SIADH, as you can see as one of the adverse effects. So of course you could get a patient who might have been given cyclophosphamide for treatment of any of these tumors, and lymphomas are listed here as well. So that's what we're talking about right now. We're looking at the lymphoma treatment. And they might have been taking cyclophosphamide, and then of course the question is going to lead on to asking about some weird water retention and urinary problems, and the problem is not hemorrhagic cystitis or bladder cancer, because that would have actually blood in the urine. Here the problem is just going to be SIADH, right, which you cannot prevent. You can't really prevent SIADH with Mesna or something. Mesna is a medication that actually binds one of the toxic metabolites of cyclophosphamide. Right, so you give Mesna to everyone who you give cyclophosphamide to in hopes of preventing bladder cancer. So that's pretty important. Then you have rituximab. So rituximab is a very high yield medication. It's one of your anti-cancer monoclonal antibodies listed right here. Right, it targets CD20, and you can use it for NHL, non-Hodgkin lymphoma. Right, so this is a very high yield medication as well, because not only can you use it for this, you can actually use it for a bunch of things. And I think one of my personal experiences that I've shared with you is that I have a friend who actually gets rituximab IV every few months for her pemphigus vulgaris. Right? So apparently this is also something you use to treat pemphigus vulgaris. It's an effective way of getting rid of the antibodies that are causing the issue in PV, right? Which is not something that's taught in the books and stuff, but it's actually a real thing. Like, they're practicing it in hospitals, and my friend has been getting those IV rituximab treatments for a year now. It's very expensive too. So this is another key medication for our topic of treating NHL, non-Hodgkin lymphoma. Last one from that was doxorubicin. So this is on page 473. Right, so if you look here for the R-CHOP mnemonic, very important to understand that the O is the doxorubicin. There's no D in here. Right, so very important. Well, again, like, this R-CHOP mnemonic doesn't really completely grasp everything, so you have to be very careful. R, C, and then O. The H is actually doxorubicin, and the O is vincristine, or something like that. I'm not really entirely sure how they get this mnemonic, like, why this, but this mnemonic doesn't capture all these medications, so you have to make sure you actually grab these, right? Remember them by heart, not simply based off of this mnemonic that doesn't entirely do the job. But doxorubicin is the last one of those, which is actually right here. It's an anthracycline that's also used to treat lymphomas, right? And one of the major effects of doxorubicin, daunorubicin both, is the fact that it's a medication. It's one of the it's the D in ABCCCD for all the things that can possibly cause dilated cardiomyopathy. And just like you can give Mesna with cyclophosphamide to prevent bladder cancer, here with doxorubicin you can give dexrazoxane to prevent dilated cardiomyopathy. Right, so it's a pretty significant thing to keep in mind, because of course most patients that are taking these medications have cancer, so they're already going through enough shit. You don't want them to suffer from more stuff, so giving all these medications, the entire cocktail of things, as well as medications to prevent side effects, is all very important. You don't want them to suffer from these unnecessary side effects. Right? Then comes the topic of Hodgkin lymphoma, predominantly B-cell malignancy associated with Epstein-Barr virus. The very simple one, straightforward, with the bimodal distribution, contiguous spreading. It's not that crazy to understand, this one. There isn't too much happening for it. Right, so this table here tells you the basics as a summary. You're going to get painless lymphadenopathy, mediastinal mass, B symptoms of fever, sweats, and weight loss. Remember that B symptoms meant that there's systemic symptoms, right? So that's what you see here with Hodgkin lymphoma for the most part. And diagnosis, as usual, is with lymph node biopsy, and you're going to see Reed-Sternberg cells with the CD15 and CD30, right? So that's all they're really going to talk about here. And for treatment-wise, right, so now, of course, all the things I said so far were step 1 related. Now for CK related, we already talked about this, the excisional biopsy and Alzheimer's appearance and CD1530. The treatment-wise is a whole new mnemonic here, right? So ABVD, which does correctly cast the letters that are involved in the names. So A here, though, fails me either way. It fails me because it doesn't really do the job for me. Adriamycin is actually doxorubicin. So I never tend to remember adriamycin, but I know that these are the medications you use because over time I've been able to memorize them. Right? It just takes time, though. It does take a lot of time. The one that I tend to forget myself is dacarbazine. It's not a medication I've ever actually seen as an answer choice, but if I ever see it in the question, it will definitely ring a bell. Right? So the ABVD here and the R-CHOP over there are very significant. You use R-CHOP regimen to treat NHL, non-Hodgkin lymphoma, and you use this ABVD regimen to treat Hodgkin lymphoma. Right, irradiation increases the risk for premature coronary artery disease and solid tumors because radiation can act in an inflammatory manner. And 5-year survival rates are 90% for stage 1 and 2 disease, 84% for stage 3, and 65% for stage 4, which you don't have to memorize these percentages per se, but the point is pretty obvious that as as the stage gets worse, the survival of 5 years is also worse. Right? Lymphocyte predominant HL has the best prognosis. That's all they mentioned there, but here we can see the general understanding. So lymphocyte rich, the one that has a lot of lymphocytes, has the best prognosis. Right, so they're going to be okay. The most common one, though, is nodular sclerosis type. Right, and all 4 of these, generally speaking, are only really different from each other histologically. There's no other real symptomatic thing per se. Right, so you can't really differentiate all of these things based off of anything else. Like, there's not much to know, and you're not really going to get a question where you have to pick what kind of Hodgkin lymphoma someone might have. This question here is from the NBME 7 for CK. If you look at it, it says a previously healthy 18-year-old woman comes to a physician because of a lump in her neck that she first noticed 1 month ago. She's otherwise asymptomatic. Exam shows a 3 centimeter left supraclavicular lymph node that is firm and rubbery. The spleen is also palpated 3 centimeters below the left costal margin. The remainder of the exam shows no abnormalities. Lab studies are most likely to show what else? And the answer was increased serum LDH. That was the correct answer for this, which is kind of weird because you don't really think of cell death very much when you see something like this. So it's very important to make sure you understand this. And that's actually the only reason I even put this question here. This young woman with a large, firm, rubbery supraclavicular lymph node, especially where it is. It's the fact that it's on the left side, right? That's also pretty important. And splenomegaly most likely has Hodgkin lymphoma. Like literally, that presentation for this woman who really didn't have any other symptoms. She's asymptomatic, just has this one thing, was actually Hodgkin lymphoma. So it's something that's very hard to catch in a question. You see, like to come up with a suspicion for something, most times we require the question to have some symptoms, some kind of problem, something that will point towards, oh, the diagnosis must be X or Y. But here, there's nothing wrong. It was simply the presence of that lump, a lymph node causing a lump. That was it. And the fact that it's painless. It's not a painful lymphadenopathy. So it was just Hodgkin lymphoma, which is actually, of course, associated with an increased LDH. Erythrocyte sedimentation rate, ESR, would be elevated as a general marker of inflammation. Serum creatinine may also be elevated in the rare case of nephrotic syndrome, which can also be associated with Hodgkin lymphoma. ALP may be increased due to the presence of liver or bone involvement, right? If the Hodgkin lymphoma has spread to liver or bone. But that's basically it. Remember that HIV workup is important because antiretroviral therapies can improve disease outcomes in HIV-positive patients. Remember that this Hodgkin lymphoma is actually heavily related to HIV patients who are immunocompromised and or patients that are immunocompromised in general. And it's also related to Epstein-Barr virus. So you can see that back here as well. So they have 2 different types, the mixed cellularity one and the lymphocyte depleted one, which are both related to immunocompromised patients. Right? So Hodgkin lymphoma is related to Epstein-Barr virus as well. It's very important to check these patients for HIV. So another CK question could have the same exact presentation of a young 18-year-old girl with a painless supraclavicular lymph node. What should you do? You should, what is the next best step in management? Check for HIV. That's something that you might not really think of. Like, what am I checking for HIV here? Well, what else is a case scenario where a young girl could have some lymphadenopathy? It would actually be something related to Epstein-Barr virus, right? Because then the other mentality would be that maybe she has infectious mononucleosis, right, from just kissing another guy. So at that point, you want to make sure you evaluate for HIV anyway. These thoughts should come to mind pretty quickly, and that's kind of how you want to evaluate this stuff. Right, very important. So this was actually a very interesting question to have here. In this image below, you can see the owl's eye appearance that they're talking about. Right, so this here is an Hodgkin lymphoma person, chest X-ray of a 27-year-old man presenting with several weeks of fevers and night sweats, showing bulky bilateral hilar and right paratracheal lymphadenopathy. So, of course, the hilum has it, and then right here you're seeing it too. Right, so that's kind of what they're pointing out in this chest X-ray. a lot of lymphadenopathy, apparently, right? And then they did a biopsy of it, which is the next step to diagnose, and of course it has this, right? So binucleate Reed-Sternberg cell, consistent with Hodgkin lymphoma. Okay, so very important to understand how this is going to present. Most Hodgkin lymphoma questions are actually very easy. The hardest part of it is to actually consider Hodgkin lymphoma, right? If you didn't think of Hodgkin lymphoma, it won't come to your mind, and then you might end up picking the wrong answer. This question with the 18-year-old girl could easily confuse you into thinking of picking an answer choice related to just Epstein-Barr virus, or picking an answer choice related to infectious mononucleosis, when the actual real suspicion in your mind should have just been Hodgkin lymphoma. Alright, so that's it. Here they tell you on physical exam, this is relevant to this NBME question down there that we just did. On physical exam, lymph nodes suspicious for malignancy are generally described as firm, fixed, non-tender, because these people with Hodgkin lymphoma get painless lymphadenopathy, circumscribed, and rubbery. They're also going to be more than 1 centimeter in diameter. Benign nodules, usually from infection, are generally described as bilateral, less than 1 centimeter, mobile, non-tender if it's viral, or tender if it's bacterial. Right? But the size and the mobility and the fact that it's bilateral or not is really critical. The fact that this patient had it on one side in this question, unilateral, only on the left side, was a giveaway for you to really, really, really consider Hodgkin lymphoma. Okay, so now we're going to look at all these questions here that are relevant to some of the topics we've talked about and discuss how to not fall for the big percentage of people that got wrong answer choices. Right? First one here, and I'm also going to be doing, as usual, the underlining what you're supposed to be highlighting when you're reading these questions, so you can focus on the correct thing as you approach these questions. So here we have a 25-year-old African-American woman coming to the office after experiencing increasingly heavy menstrual cycles for 3 months. So the most significant thing in this first sentence is the fact that she's AA, she's African-American, so I would definitely highlight that. And then I already get the key problem, so I never really tend to highlight the key problem. Her presenting issue is heavy menstrual cycles. Okay, got it. She's also noticed that her gums frequently bleed when she brushes her teeth. So now that I'm going to highlight, because then I'm starting to see what could be happening here. This seems like a platelet problem. Review of systems is positive for ongoing pain and stiffness in her hands and wrists that is partially responsive to ibuprofen. So that sounds like some level of rheumatoid or osteoarthritis, most likely rheumatoid. She's not taking any medications, doesn't have any medical conditions, she's afebrile, blood pressure is high, right? Everything else this is okay. Non-painful oral ulcer is present. So this is actually a giveaway for what's wrong with her. Once you study the topic, this is actually a giveaway of what she has, which of course, being African American, makes the suspicion even easier. Multiple petechiae are present on the upper arms and shins. The wrists and hands are tender to palpation and demonstrate reduced range of motion. So I'm going to highlight the petechiae. I don't really care for her osteo issue, right? The fact that she might have rheumatoid arthritis, that's not what I'm really caring about right now, the stiffness that she's having. Because she didn't present to me in this clinic right now talking about her stiffness. She came because she's been having heavy menstrual cycles. She's a young woman with heavy menstrual cycles. That's what she's concerned for. Then they go on to tell you some more lab results. So hemoglobin 10.8, platelets are very low. Right, so we're seeing some problems here. Leukocytes, creatinine. There's a bunch of problems. All her labs are messed up. What is the most likely cause of thrombocytopenia in her? So 50% of people pick the correct answer of peripheral destruction. That's what happens here. But the truth of the matter is, most med students that I've spoken to about this question didn't really know that lupus, which is her problem, actually has peripheral destruction of platelets. They've never really seen that. 20% of people chose ineffective hematopoiesis. 17% of people chose aberrant splenic sequestration. The fact that all of it is for some reason sequestered in the spleen. All the platelets are put away over there. And then 12% chose bone marrow invasion by some malignancy. Right. This patient's presentation suggests possible lupus, a systemic autoimmune disorder. Her severe thrombocytopenia, manifesting with common features of bleeding gums and heavy menstrual periods, is likely due to lupus. In the United States, lupus occurs most commonly in African American, Hispanic, and Asian women, but for the most part African American, especially as far as STEP is concerned. Hematologic abnormalities occur in over half of lupus patients, and as described in the table below. Right, so both of these tables. So if we look at it here, they're going to have anemia, leukopenia, and thrombocytopenia. So that's basically what's happening here. The presence of autoantibodies is the primary mechanism underlying the most common cytopenias in lupus. Thrombocytopenia is most often caused by antiplatelet antibodies, which trigger increased destruction of platelets by immunoglobulin building, uh, binding probably, I don't think I meant building, binding in peripheral blood vessels and subsequent macrophage phagocytosis, right? So it's autoimmune destruction of your own platelets. That's it. Less commonly, which makes this a more testable topic, let's know what I'm putting there, thrombocytopenia can occur in lupus-associated hypercoagulable states in which platelets are consumed within thrombi. Right, so that would be your TTP associated with schistocytes or DIC, which can occur in antiphospholipid antibody syndrome as well. So very important to make sure you get that, right? I put the TTP in the table as well. It's right here. So you have to make sure you know what's causing each thing. So of course you have to know lupus can have one of these three things, and then for each one you need to know why. So it's a pretty in-depth topic to make sure you master. You have to look at it. And then the other answer choices didn't really make much sense. Malignant invasion of bone marrow may cause pancytopenia, but pancytopenia can be caused by and pancytopenia also can be caused by ineffective hematopoiesis. However, these conditions are unlikely to explain her new kidney disease, which is the creatinine issue, hypertension, right, which we also highlighted, and the non-painful oral ulcer, as well as her arthralgias, right? Those are not things you would see if her only problem was really just malignant invasion of bone marrow, or her only problem was ineffective hematopoiesis. Then the other thing, splenic sequestration of Ig-bound platelets may occur downstream. That is something that can occur in lupus. The primary initiating mechanism for platelet destruction in lupus occurs in peripheral blood vessels via the abnormal formation of immune complexes. In contrast, aberrant splenic sequestration occurs in conditions that increase portal pressure and splenic congestion, such as liver disease, hepatic vein thrombosis, or even sickle cell. Typically, the thrombocytopenia with these conditions wouldn't be that severe. It would be pretty mild, and they may have some of these symptoms, but it wouldn't be extremely bad. So a lot happening, a lot to catch, because lupus itself, also known as the great imitator because it can imitate so many different diseases, is an extremely complex disease, but it's because of the fact that it's so complex, it's pretty easy to catch because it just encompasses so many issues in the same person, as you can see in this person. This one woman who they didn't even need to tell you is an African American woman. Without even that knowledge, you can already tell that this is definitely lupus because of the fact that she has all of these issues in the same one individual. Next question here is about Hodgkin lymphoma, right? So we said that non-Hodgkin lymphoma is very intense. There's a long list of them. There's many different types, but Hodgkin lymphoma is the easier one to test on, but also it's easy to make questions on it, but it's harder for students to catch it because many students don't often tend to think of Hodgkin lymphoma at all, right? The first thought to come to mind is very rarely Hodgkin lymphoma, which is just because of the fact that it's not that common, which is a good thing. Good thing Hodgkin lymphoma is not that common in reality or on the test. But when you read a question, that suspicion needs to come to mind. And you're going to see why that's a suspicion that should come to mind and not what the other 30 and 20% of people chose. 65-year-old man is brought to the emergency department due to chest pain. So I'm going to highlight the age because this is always pretty significant once they're over 60. He's had fatigue, retrosternal heaviness, and a non-productive cough for several weeks. So I'm most concerned from this sentence with the retrosternal heaviness behind the chest, behind the sternum, I mean. Today, he developed severe chest pain at a retirement party after drinking a beer. Okay, so I'm very keen when someone says they have chest pain because having worked at a clinic that was mainly full of people from Bangladesh, and of course people from my own country, India as well, this clinic had many people that would come in and say they have chest pain, but it was really just GERD or just muscular pain from the work they do. Right, that's the costochondritis that can occur where you can do palpation of the rib cage and they'll feel pain, giving away the fact that it's not chest pain related to atherosclerosis or coronary artery disease, any of that stuff. So when it says this person has chest pain, I'm still not highlighting that because I don't know if this is something that's going to require an ECG or is this something that's another case scenario. All right. So all they're still talking about is that he had a beer at some retirement party and got severe chest pain. Okay. He has no chronic medical conditions, doesn't take medications. He doesn't smoke, but he drinks socially. Temperature's fine, blood pressure's not so bad, pulse is fine, so his vitals are okay. Physical exam shows clear lungs and a normal heart sound. ECG is also perfectly fine, so it doesn't look like it's actually chest pain. Right? It doesn't. This might be one of the differentials of chest pain. So then you order something to check what's happening, right? So chest X-ray. So of course ECG was easy to do. You do it. You check if he's got some ST elevation or depression, and you would see maybe he's at risk of an MI. That didn't happen. So now you do a chest X-ray to see why he has this retrosternal heaviness. Is he bleeding behind the sternum? Is there something else wrong? Chest X-ray shows a large anterior mediastinal mass. Right, so I'm going to highlight the word X-ray because I know it's important to look at. I'm not going to highlight the entire X-ray finding. I don't want too much highlighting done. I'm just highlighting the fact that I should care about the X-ray. Right? Large anterior mediastinal mass displacing the trachea. So usually in the real world, most med students, when they read something like this, they immediately think thymoma. But a 65-year-old man is not going to have a thymoma. It's very unlikely. And if there is going to be thymoma, then keep in mind that there was association of musculoskeletal disorders as well, right? So right here, when you look at neuromuscular junction diseases, thymoma is most commonly found in patients who have myasthenia gravis. And our patient doesn't have a single symptom of myasthenia gravis from everything we've read, at least so far. They do his labs, hemoglobin's low, right? Platelets fine, leukocytes. Okay, so in leukocytes, we're finding something that's always important to watch for when you're working in oncology. This person has eosinophilia, right? 10%. There's no reason for him to have high eosinophils. So when it is high, it's usually some kind of lymphoma or leukemia kind of thing. Serum LDH is also very high, which is actually the giveaway for the lymphoma. This is relevant to our previous question right here, right? Increased LDH. So you see the connections between these questions. They're all testing you on the same thing, but they're asking you about a different topic. But it's the same exact thing. So in that question, the answer was increased LDH. In this question, they're telling you he has increased LDH, which is also going to be a giveaway for the fact that it is lymphoma. Troponin I is normal because we already know from the ECG and troponin I and the fact that I'm disregarding the chest pain aspect that it's not chest pain, it's not coronary artery disease. We figured that out. There was no reason for you to really highlight chest pain until you read the question and you see something that the question is actually leading towards angina, that the question really is about a potential MI. All right, this question doesn't sound anything like he's having an MI. Right? He got chest pain after drinking a beer. That's not how MIs occur. Chest pain after trying something exertion, like walking too much, running, lifting something heavy, that could be coronary artery disease. Not after drinking a beer. That's not how MI works. What is the most likely diagnosis? It was really easy. You just pick Hodgkin lymphoma. Because as I told you, Hodgkin lymphoma is an extremely easy topic. However, because it's so asymptomatic and there's nothing ever wrong with these people, it's also something we don't tend to think of. Right, but you have to get good at that. You have to get good at thinking of that. So it was Hodgkin lymphoma for two key reasons. His age, the chest X-ray, actually 3 key reasons, excuse me. His age, the chest X-ray, and the eosinophils. The presence of high LDH only further confirmed the suspicion that I developed after looking at those 3 key reasons that it's definitely Hodgkin lymphoma. 20% of people chose germ cell tumor and 30% fell for thymoma, which was really pretty ridiculous. How could you think there's going to be thymoma in a 65-year-old person when we as newborns pretty quickly lose our thymus anyway? Right? And this person doesn't have myasthenia gravis either, where there is a thymoma association. And of course, remember the other one as well, Lambert-Eaton has a small cell lung cancer association, but none of that is happening in our patient. Right, so this patient had several weeks of fatigue, non-productive cough, retrosternal heaviness, and then developed acute chest pain at a party. Although evaluation reveals no evidence of acute coronary syndrome, the presence of a large mediastinal mass, elevated LDH, and eosinophilia raised strong suspicion for HL. So you see, these are the 3 key things you're looking at. Well, they're saying elevated LDH. For me, it was the age, but sure. 3 key things to look at for suspicion of HL. Right? For me, one of the 3 things was different. I didn't look at LDH to develop a suspicion for HL. I developed a suspicion for Hodgkin lymphoma just because it's a 65-year-old man who has a large mediastinal mass and eosinophilia. That's how blurred and non-specific diagnosing Hodgkin lymphoma is. You're going to get a patient who shows up with the complaints that are about a mediastinal mass, and he's calling it chest pain. right? And then you're going to have this eosinophilia on labs, and that's when you immediately have to refer the patient to an oncologist, because this is most likely someone who has lymphoma, right? A lymphoid neoplasm that most often affects the bimodal distribution, young or really old. It generally develops in a single lymph node and spreads to contiguous nodes via the lymphatic and thoracic ducts. Although most patients have painless peripheral lymphadenopathy in the cervical and supraclavicular chains, about 50% of cases are marked by significant mediastinal lymphadenopathy, like this guy. This can compress adjacent structures and lead to cough, shortness of breath, and even retrosternal chest pain, irrelevant of cardiovascular stuff. Patients with Hodgkin lymphoma can present with severe pain in areas of lymphadenopathy following exposure to small quantities of alcohol, as likely occurred in this patient with a mediastinal mass who developed severe chest pain after drinking a beer. The etiology is unclear, but may be due to vasodilation in the lymph node following alcohol exposure, causing capsular distension. So they're explaining why after the beer his lymphoma mass started acting up. Okay. Patients also frequently have long-standing fatigue, B symptoms, which are systemic symptoms, and pruritus. Those are the things you see in Hodgkin lymphoma pretty much 100% of the time on STEP. Lab evaluation often reveals normocytic anemia, right, because it wasn't microcytic. Between 80 to 100 is usually considered normal, but he does have anemia. Eosinophilia, because tumor cells actually secrete cytokines that generate eosinophils. Very important thing to remember. So if someone has high eosinophils, you really need to consider why. Why do they have high eosinophils? Is it because they have asthma or some kind of other allergic thing? Then maybe it makes sense. Otherwise, it's tumor cells secreting cytokines that are actually causing eosinophil production. Now, as a bonus question, you would want to ask yourself, which cytokine was it that made eosinophils? Right? How did that occur? And if you don't remember it, then you go back to step 1, first aid, and you go revise which cytokines did what, because that is something you have to remember until you're done with steps. You know, it's very unlikely you'll get tested on that, but it's something you do need to know, no matter what. Lymphopenia and elevated LDH because of the high tumor burden. The diagnosis is made when you actually do a lymph node biopsy and see the Reed-Sternberg cells, and that's all it is. Thymoma, even if it was possible for it to have it, won't have eosinophilia or worsened pain with alcohol, and most patients would have myasthenia gravis as an association. So that made no sense for 30% of people to pick. Next one here, 5-year-old girl. So this is a question about ALL, acute lymphoblastic leukemia, which we also called adolescent little leukemics, right? 5-year-old girl. So I'm going to highlight that age because remember, anyone that's very young, under 18, and anyone over 60, I highlight because they're part of a different demographic of issues that can occur in them. 5-year-old girl is brought to the office by her mom and her boyfriend due to leg pain. So these kinds of questions actually, I often also keep in mind as soon as I read that, the potential for child abuse. And that it's the mom and her boyfriend, not the husband, not the father of the girl. So there's something that can occur, so you want to keep that in the back of your head. And if the question starts going towards child abuse, you really start working on that suspicion to check. 1 week ago, the boyfriend saw the patient fall onto the living room floor after climbing a couch. Now that sounds very suspicious. Right? It does sound like this might be a question about child abuse. Since the incident, she has had persistent leg pain that appears to be worse at night. So, okay. And for the last 2 days, she has been refusing to walk, asking her mom to carry her. She has no chronic medical conditions, but has had a mild non-productive cough for the past month. Non-productive cough for a month. Okay. Temperature is high, but all the vital signs are normal. Height and weight are at the 20th percentile, which is acceptable. Exam shows a pale child. The abdomen is non-tender and the liver is palpated below the costal margin, so she has hepatomegaly. Palpation of the bilateral anterior proximal tibias elicits pain. Bilateral. Oh, they didn't say if she fell on one leg or not. Okay. So she has pain. There are a few scattered bruises across the chest and the back. That's really weird too. That also actually points towards potential for child abuse. The remainder of the exam shows no abnormalities, and then you do CBCs, and now you know it's not just about child abuse. A child going through child abuse wouldn't just randomly have anemia, and this is pretty bad anemia, and really bad thrombocytopenia, and even, this is pretty concerning. So now you're like, oh, wait, something's actually really bad here. So what's the most likely cause of all her symptoms? It must be ALL, simply because of her age. Adolescent little leukemics. I'm not going to pick anything else for this question because nothing else really fits. Her bone pain and pancytopenia are concerning for ALL, the most common leukemia in kids. Bone pain is caused by leukemic infiltration of the bone marrow and typically affects long bones. At night, the dull pain is often more noticeable, and during the day, children may limp or refuse to walk. The invasion of cancerous cells in the bone marrow also results in pancytopenia with anemic pallor and thrombocytopenic bruising, which she has. She has all of that. Fever is a common non-specific finding that, of course, the test writers are going to use to trick you and confuse you and whatnot, because they can easily reword this question to mention something where you might start thinking this patient might have osteomyelitis or something, due to some infection. But that's not the problem here, because even that wouldn't have these CBC results, right? The CBC results, remember, labs don't lie. This is what's actually giving away what's truly happening. Aplastic anemia, which was what 35% of people chose, would also have pancytopenia, but the hypocellular bone marrow of aplastic anemia does not cause bone pain. Right? So then, how could it be aplastic anemia? Right? Aplastic anemia has bone marrow that's pretty much dead, not doing anything, so there's not going to be any bone marrow pain, bone pain. Right? So that's all there was. One little fact was enough to knock out that answer choice. It's a very perfectly demonstrated question for ALL. This one here, this question is also pretty interesting because this is a not so heavily tested topic, but it's one that can pop up on your test. You want to make sure you grab it perfectly. So to review this, we're going to have to go back to, I believe it's somewhere here. Anytime you're studying cancer, you always have to go back to your immunology chapter in step 1, right? So here we're seeing an 18-month-old boy, so again, very young, so I'm going to highlight that, brought to the ED due to blood in his stool, which the parents noticed when changing his diaper. So I don't tend to highlight this all the time because here I'm going to remember it. The main problem is just blood in the stool and the diaper. Okay. Infant has had no previous bleeding and has been eating and drinking normally. He has a history of recurrent otitis media, so this is pretty significant because now, as soon as I read that, recurrent otitis media, this often reminds you of cystic fibrosis, possibility, but then they go out of whack because then, okay, otitis media is usually bacterial, frequent herpes labialis, so that's viral, and 2 episodes of pneumonia, which could be bacterial or anything else. So this is pretty weird. Now it's sounding a lot like some kind of immunodeficiency problem. Vital signs are normal. On exam, he's well developed, well nourished, and has a fair complexion. Which, again, I'm not sure if the parents are just white or is he just more fair than he should be. He has eczema on his cheeks, trunk and extremities. Scattered petechiae are also visible, so he's missing platelets. Right. Remainder of the physical exam is fine. Lab studies show platelet count that's very low. Peripheral smear confirms low platelet count and that the platelets are small. So this is typical UWorld telling you too much in a question, because as soon as they tell you platelets are small, the answer is very clear. Then they go on to say genetic testing confirms the diagnosis. What's the most likely affected by his gene mutation? So the answer was just cytoskeleton regulation, but you have to remember what this disease is, Wiskott-Aldrich's. While 20% of people chose antibody class switching, DNA repair, and maturation of T cells. 20% each. That's 60% of people chose these 3 wrong answer choices. That's terrible. This patient's eczema, microthrombocytopenia because they're small platelets and they're missing, only 24K, and recurrent infections are consistent with Wiskott-Aldrich syndrome caused by an X-linked recessive defect in the WAS gene. I like to call it the WASP gene because there's usually a lowercase p there as well since it's on the P arm. The gene is primarily expressed in the hematopoietic cells and regulates cytoskeleton remodeling. In response to cell signaling, in Wiskott-Aldrich, the actin cytoskeleton in white blood cells is abnormal, resulting in immune dysfunction due to impaired cellular migration and immune synapse formation. Patients are at increased risk of recurrent bacterial, viral, and fungal infections, as we can see in this patient. Right? Pneumonia could often be fungal. There's a bunch of them that cause pneumonia. Similarly, the cytoskeletons of platelets is also dysfunctional. Virtually all patients have significantly decreased platelets and they're going to be tiny. The resulting clinical findings can range from petechiae to purpura to severe bleeding, such as intracranial hemorrhage, hematomesis, or hematochezia. So they're in a lot of risk. Other answer choices that people chose: hyper IgM syndrome has T cells that lack CD40 ligand and cannot activate B cells to switch their antibody isotope. So this was wrong. That's not what's happening here. This is not a question just related to not being able to switch isotopes and make the correct antibodies, because this child is also getting viral and fungal infections, not just a bacterial thing. Ataxia telangiectasia would actually show you both of these symptoms. It's a T cell deficiency associated with a defect in DNA repair. Right? They have progressive cerebellar degeneration, which is what causes the ataxia, irrelevant to our patient. And then severe combined immunodeficiency, this last answer choice, maturation of T cells, DNA repair, right? All three of these, is also a T cell deficiency due to gene defects that prevent interleukin-7 related maturation of T cells in the thymus. Also irrelevant to our patient, because this question wasn't just about antibodies, just about B cells, or just about T cells. It wasn't one of the three guys. No, it was about everything not working and a lack of platelets, right? Which, severe combined immunodeficiency wouldn't have a lack of platelets, nor would the platelets be tiny. When you study your immunodeficiencies, you need to study them the way they are here. B cell disorders, T cell disorders, and then combined shit. The guy that we're looking at right now is Wiskott-Aldrich right here. A mutation in the WAS gene. I like to remember the lowercase p here. I write it like that, WASP gene, because the lowercase p reminds me of small platelets. Okay? And then there's another mnemonic I like. They have the mnemonic water to remind you that Wiskott-Aldrich has thrombocytopenia, eczema, and recurrent infections, as we saw in our patient. But I use this mnemonic water game to remind me that when you write water game, you had the letters A, right? The letters A and E repeated twice. You write AE in water and AE in game. That means that IgA and IgE are going to be elevated. And the other two, IgG and IgM, which are the other two letters of the word game, are going to be low or normal, but mainly not high. That works perfectly for me. Water game WASP is the perfect way to remember Wiskott-Aldrich syndrome. And when I see a patient in any question where they're having eczema and thrombocytopenia, I immediately think of this because that's part of the water mnemonic. Okay. Great topic, but again, it's very easy to get confused between all of these, right? And which one is it? Which one does the patient have? Why does he have this disease or that disease? How do you differentiate? You have to study these in pretty good depth and really catch what the unique thing is going to be for each one so that you know how to pick it correctly, right? And that's what happened in this guy. So this was just Wiskott-Aldrich. Great question for Wiskott-Aldrich. And then here now we have a question on AML, which is what we called the aged men leukemia, right? Median age 65. But look at this. This guy is not anywhere close to 60. He's a pretty young guy. 32-year-old man comes to the emergency department due to a persistent nosebleed lasting an hour. So this is pretty weird, right? 32-year-old person doesn't really tend to get nosebleeds. It occurs in kids, but not a grown-up man. Over the past week, he has had several episodes of epistaxis that stopped after prolonged nose pinching. So just applying pressure helped. Okay. One of the most common reasons a grown-up man might actually have a nosebleed is because of snorting cocaine and stuff. That's something you want to watch out for. He has also noticed more fatigue and skin bruising than usual over the month. So fatigue usually means anemia. Skin bruising usually means lack of platelets, thrombocytopenia. But again, this is not proof. Labs are the ones that don't lie, so we have to check labs when we get there. He has not had any recent nasal trauma or upper respiratory tract infection, and doesn't use any intranasal medications, and I'm guessing he doesn't do drugs either. Yep, so nothing. Right? And he has a vegan diet, which is kind of significant, right? Because without meat, you're not really taking in much B12. Temperature is 99. I'm not really going to highlight. That's okay. Pulse is on the upper end, but generally speaking, his vitals are okay. Physical exam shows dried blood in the right nostril with no intranasal lesions. No enlarged lymph nodes are present. Lung fields are cleared auscultation, and heart sounds are normal. So in any question, if you ever do see enlarged lymph nodes, I want you guys to always, as soon as you see enlarged lymph nodes, start evaluating for Hodgkin lymphoma. And then if it's not Hodgkin, check for non-Hodgkin lymphoma. right? Because you need to evaluate for lymphoma anytime you see lymph that are big. This guy doesn't have any large lymph nodes, okay? Lung fields are clear at auscultation, heart sounds are normal, abdomen is soft and non-tender, no hepatosplenomegaly, so all of that is okay. So what is wrong? Well, you have scattered ecchymoses, okay? And labs show you hemoglobin is very low, platelets extremely low, leukocytes, coagulation, PTT44, fibrinogen 140, LDH is also high. What the heck is happening to this guy? Well, they want to know what is the most likely associated with his condition. So this is a second-degree question. Primary question will be to ask you what's wrong with him. Secondary question is asking you, now that you know what's wrong with him, tell me what else you would find in this patient. So if you don't know what's wrong with him, you can't answer this question anymore. And then a third-degree question could be about, what would you manage him with, or any of these, like what else is this disease similar to, etc., etc. So the correct answer here was atypical promyelocytes in the bone marrow. 60% of people did correctly pick it, while 15% of people chose decreased von Willebrand factor activity. Now remember, for STEP purposes, von Willebrand disease is autosomal dominant, so it usually occurs in women on STEP, and the men are going to get the X-linked hemophilias, hemophilia A and B. So that's just a STEP thing. Of course, men can get von Willebrand as well. Women are very unlikely to get hemophilia because both parents would have to have it, and they would have to selfishly pass it on to the child, which is very rare. In fact, nearly zero. So how did you figure out for this question that this patient has AML? Well, he has fatigue, prolonged bleeding, easy bruising. He's got pancytopenia. He's also got a coagulopathy, right? Because he's got coagulation factor. The PT and PTT that they gave you are not exactly ideal. So coagulopathy and elevated LDH strongly suggesting acute promyelocytic leukemia, which is a form of AML. This is APML, right? The one that's often got nothing to do with Down syndrome. That was the whole different set. So if we go back and look at it real quick. There was AML, and then there was another variation in there with APML that you have to make sure you understand the differences of. Right, APL, this one, which has translocation 1517, is the better one because you could give vitamin A and arsenic and they'll start recovering. They might get some DIC, but they'll be okay. This one has nothing to do with AML, really. AML is a different one that has the myeloperoxidase, the Auer rods, and it's more related to Down syndrome. Right, so Down syndrome and all these other issues that they can have. That's the AML. Our guy doesn't have AML per se, but he's got a different variation of it. AML is a clonal myeloproliferative disorder characterized by the accumulation of blastic or immature myeloid cells in the bone marrow and peripheral blood. Patients often develop fatigue and symptoms related to one or more cytopenias, including fatigue, weakness, thrombocytopenia, and granulocytopenia, because without those guys, they're going to end up getting infection. Examination shows pallor and ecchymoses just like our guy. And generally speaking, the main thing was the fact that all of these things are so low. Right? That's the main thing to understand. One unique type of AML is APML, characterized by life-threatening coagulopathy due to DIC. Bone marrow biopsy of APML will reveal atypical promyelocytes, which was our answer. That's it. Right? So this is a pretty straightforward thing. With here, there's a table as well to help you understand what you're looking for. The difficulty in these questions is simply based off of whether or not you know that you're supposed to be looking for something. Right? If you're unable to develop the suspicion to actually look for something, then you're open to falling into a bad trap that one of the answer choices might lead you to. Right? You're searching for the answer. It's not that the answer choices are helping you search for the correct answer. Alright, so that's it for that. Now we're left with plasma cell disorders, transplant medicine, and neoplastic diseases to wrap up Heme, and we'll do all of that on Wednesday. Thanks a lot for joining, guys, and I hope everyone's doing well.